1 second, please.
So while Natalie's making me a co-host so I can open my presentation, I want to say that I'm very pleased to communicate with Greek doctors. Greece is a special country for me for many things. First of all, that I know Natalie for many years, and I'm very pleased that Natalie represents MS company because I think it's a mutual luck for the company and for Natalie. And at the same time, I think Greece is the only country where I can pronounce my name without changing it or accommodate it for the country's abilities to pronounce. I'm Leonid, so very Greek name that was very popular in Jewish families, actually. So here I could be the Leonid for you, and that's good. And let's start. So let me share the screen. And so, hello, dear colleagues. For me, it's a great honor. And when I hear that someone is saying that I'm a speaker, a lecturer, there is nothing like that. I have to tell you the truth. I'm an ordinary doctor, absolutely ordinary doctor. I'm a prosthodontist. I had 10 years of experience of being an orthodontist, but then for the sake of my patients, I decided to quit being an orthodontist. I was not very pleased with the results I was getting, but I managed to delegate the patients who were coming to me in search of orthodontic treatment to the orthodontist I could trust, my wife. So, and I was in a position as a prosthodontist to make the decisions for the treatment plan for everybody. So, and I was searching for many ways how to collect the information, how to make the data acquisition, and how to process this information for the better communication with the members of the team. Of course, the main member of the team is dental technician, so I had to provide the information for the technician that he would not use his imagination, but he would use the objective data in order to produce some kind of result for me. And of course, I needed to give information to orthodontist, to endodontist, to periodontist, but it was a process in itself. The data acquisition was quite a, I would say, quite a bit of work because it required a lot of time and a lot of effort to get the data, then to process it. And at the same time, everything was not connected in order to get the result. I was feeling that I have bits and pieces of information because I had CBCT that I had to analyze and I didn't trust to any radiologist to do it for me. I had cephalometric analysis, which I think is more applicable for the prosthodontist than for the orthodontist. I had a lot of pictures. I had models and I was analyzing the occlusion in the articulator. So I was using many things, but at the same time, it all had to be connected inside my head because I was forced to know what I've seen on the CBCT. I was forced to remember what were the conditions of the condyles. At the same time, I have to somehow to see the occlusion in the articulator, and I have to think about the aesthetic result of the elongation, for example, of the teeth if I want to do walks-up, and then to try in the mock-up in the mouth. So, and then accidentally, I will tell you the story because I think it's an interesting story. About 1 year and a half, I was on a congress and I was listening to the lecture of my very close friend, Leonardo Bacchiarini. And he was presenting the system for the jaw tracking, the system that came from France. I will not tell its name, but you know what I'm talking about. And I was so mesmerized by that because I had experience of doing a lot of condylography being a Slavic student. So, and when I've seen this system, I decided that I want this system to be in my practice because what I lack is the jaw tracking device and give the information about the lower jaw movement. But then it turned out that it was quite expensive system, first of all. And the second, it turned out that I couldn't get it because of their certification problems. And then I got acquainted accidentally on another congress with the developer of the SDiMatrix. And I just, being idealist and being very sincere, just approached him after his perfect presentation and told him, Eugen, your system good, but I want another system. He told me, okay, this another system is very good, but why do you need it? Because we have much more. And that hooked me up. I'm asking, what more do you have? He said, well, axiography and jaw tracking is only part of the equation, but you need to process information, and you need to use this information according to the phase. You need to like this information with the data about the skull, the CBCT, and you have to make not only the decisions, but also you have to put the diagnosis, and you have to also try to think about different options of treatment. So that got me interested. And what I did is I started to look more about SDiMatrix system. And it turned out that this system is everything I dreamt about, because this is what was lack in my protocol of data acquisition. And I'm very pleased that it, fate as it is, saved me from more expenses of getting much less. And I spend much less money and got much more. So it's all started from this. So this, what you see right now, are the models that were created by the developer of SDiMatrix. Around 10 years ago, he was an opinion leader of the famous company that also sold the optical, ultrasound axiography. So what he did, he had a genius idea in his mind. So what if he would use the data that he was getting from the ultrasound jaw tracking device and would feed this data into a robot that will be in charge of movement of the lower platform of the model. So it was the same as, the platform for airplanes, where a special devices to simulate the airplane in the air. So this was the same hexapod robot. So they programmed their robot to repeat the movements that were according to the axiography that we were recording. And it turned out that this robot, this lower model, was breaking the upper model. So Eugen approached the company and said, guys, the model represents exactly the movements that you have. But I think that the way we recorded it has some kind of mistake, because the upper model is always breaking. So we have to find a solution not to have it anymore. And they said, okay, we have a solution. You're not working for us anymore because our system is good. As it turned out, they were not right. But Eugen, he decided that he has to find out why the ultrasound axiography was not precise. And he started to think about the way to make the jaw tracking more accurate, more precise. And then he came up with the idea of SDiMatrix protocol, which is in itself is very, very easy. So what is SDiMatrix? First of all, it's device itself, the hardware, the axiography. And let's see how the procedure starts. So it all starts from inviting the patient to the chair. And when we invite the patient to the chair, first thing that we do, we use the thing called central marker, which is the heart and soul of the system. You can also think about it as a digital phase bone. So the central marker here also is connected by the magnet with the bite fork. We apply the bite registration silicon material on the bite fork, and we apply the fork on the upper teeth. When the material is finally set, we ask the patient to close the mouth and the cotton rolls, and we ask the patient to stand up and approach the mirror. And the patient has to look himself or herself in the mirror, in the eyes, and then press the button, because there is a Bluetooth signal that goes to the software. And in the digital phase bone, there is a gyroscope. So we register the natural head position that in 90% of cases is coincident with a true horizontal level. Then we apply the flex incomplete bonding protocol on the upper right canine and lower left canine. We don't etch, we just apply the adhesive and the flowable composite. And this is a special optical camera. This is very special camera because it is the same camera that is used by traffic policemen to make very nice HD pictures of the driving of the license plate if you are speeding on the highway. So we apply the camera on the head, and we can adjust the camera on the head anytime we want, because it doesn't matter. What is matter that by applying again a central marker, we feed to the system information about the position of the upper flag that is stationary, it is not moving. Lower flag could be moved. So that we do the recording of several jaw movements. The three of them is what we call uncontrolled, open, close, go to protrusion and lateral protrusion, then guided movements when patient has to slide on the teeth and protrusion and do lateral protrusion, and free movements when patient has to repeat these movements but without the contact between upper and lower teeth. You can add to it whatever you want. I added to that protocol the speech, the chewing, and sometimes we can also try to simulate Brack's activity if we want to. And then this information will be analyzed in the software. So besides that, in the portfolio of SDiMatrix, they have the wireless electromyography and also the TENS unit, which is actually the same device that you put in the collar, and you can make the electromyographic recording of the masticatory muscles. And as a bonus, you can also do the face scan of the patient. So we have a complete digital version of the patient, where you digitize the patient. The face scan is performed very easily right now. You don't need to use a photo camera. You can just use your iPhone. You do the magnification in iPhone 3.2, and you don't need to do 30 pictures anymore. As far as I've heard recently, it's enough to do about maybe 12, 16 pictures around the patient, and then you upload them into the software, and the software will construct the 3D scan of the face. So the protocol itself, I would say, take about 15, 20 minutes, maybe less. Or if you wanted to exercise more movements, maximum it will take about 30 minutes. And I can compare it, for example, with the condylography that took from me about 1 hour and a half just to get the recordings done. I'm not talking about even processing of the information. So after that, I purchased the equipment. Now I decided that I need to test it. So I want just to show you the first patient that I ever did axiography. This patient before 1 year, maybe before of that, she was having experience with condylography. So I think that I doubt it could be worse than condylography. So, but I was interested in a patient experience about that. So here is how it was. So as you see here right now that my assistant even didn't know what I was doing here. So I just told her directly, we need this, we need that, okay. And she was just following the orders. So there was nothing extraordinary for the assistants, absolutely. It's just business as usual, I would say. And the patient was feeling quite okay. So the main thing is that when you bone the upper flag, maybe I made a mistake here because the flag has to be rotated a little bit inward. Don't put it upward. On the flag, there is a black dot that has to be oriented towards the ear. So not to mix them up. Yesterday we had a question in the chat when jaws were moving in different directions. So here on a little dot, it has to be oriented towards the ear of the patient. And when we apply the lower flag, we ask the patient just to close the mouth so the flowable material would not interfere with the upper teeth. If the flag debonded during the procedure, is nothing dangerous. If the lower flag debonded, you just can apply the material again and put it back on the canine. If the upper flag debonded, the only difference that you have to do is you have to also to show to the system central marker again. It's very important when we do the movements that we have a 0 point. For us, 0 is ICP, or you call it IMIP, or just occlusion. So habitual occlusion of the patient, or maximum intercuspidation. You can call it any way you want. So between each movement, forward, backward, wide, left, backward, wide, right, backward, wide. So we have to have this 0 point. So when we did all these movements and recorded them, the last thing that we have to do is we have to scan the upper fork with bite registration material on the upper dental arch. And this protocol still exists, but as far as I know, this protocol hopefully will be changed for the more easy protocol, just to scan the bite fork with the silicon material, and artificial intelligence would then just combine this fork with the upper dentition. This we need just in order to have the coordinates of the models into the software. And so in my protocol, there are 6 major recordings. It's uncontrolled movements where we don't instruct the patients how to do that, and we just record the stereotype of the movements that the patient has. We have guided movements to see how the teeth are sliding along each other of upper lower jaw. Free movements when the teeth could not be in contact during the protrusion or protrusion speech, and two types of chewing. When you ask a patient to imagine if the patient is chewing some hard food, and ask the patient to imagine that he is chewing some leathery, very fibrous food, so we can see different chewing patterns. And then in the end, if you want, you can make a set of photos. Once again, with the iPhone, it's easy, or any smartphone, it's much easier. Just don't forget to put this sticker. Right now, they have a new version of the central marker that would make the use of the sticker obsolete, because the central marker would be at the same time used for the construction of the 3D face. If you doing the pictures of the smile, you just have it as a smile. But if you do the pictures with the lips closed, then you can simulate the changes of the soft tissues in case of this changes of the position of the lower jaw on the screen. And so before I go on, how do you hear me, first of all? And is it okay about the pace, about my language, about my accent? Are you okay, guys? Just give me some feedback if it's possible. Is it all right? Anybody here, or am I alone?
For me, it's okay, but I can hear you great.
Okay.
It's okay, yes.
All right.
Okay,
So
yes.
let's make it also interactive, because what I will show right now, I don't know the level of the audience, and I don't know what you want. So let's make it like this. If you want to interrupt me with a question, just go on, please do that, because it's sometimes when we present the system, we present it with our own footprint, how we use it. But you don't need to use the system in that way, because what is good about the system in itself, that you can use it just as simple jaw tracking device. So you can record the trajectories and give the information directly to the dental technician. That's it. You don't need to do anything more. And I would say maybe in 60–70% of your cases, depending on the practice, that's the way you're going to do. But you can also do much, much more with the software. And I want to discuss this much, much more. So when we recorded the axiography, it's already recorded in the...
Excuse me.
Yes?
I'm K-Pal. I'm Kostas, first of all.
Nice to meet you, Kostas.
Good morning. I
Good
would
morning.
like to ask something. Before
Yes.
you go on and you do all these recordings, what exactly is your starting point? I mean, the teeth are in central occlusion or in maximum decuspation?
Well, it's a semantic question, Kostas, because centric occlusion...
I am also prosthodontist. That's why I'm asking that.
Yeah, so let's make it easier. Maximum intercuspation. So, or habitual occlusion of the patient, because if we start to argue about centric occlusion or centric relation, definitely not centric relation, and also definitely not what we call hinge axis position. So patient between each movement has to bite on posterior teeth. That's how we instruct the patient. So patient open mouth, bite. Patient goes forward, then go back, bite. So for us, 0 point, or to make it easier for you also to understand, imagine you scanned the jaws. Yes, you scan upper and lower jaw, and you scan the bite. Yes. So this what you have also to try to have in the mouth when you do axiography, because you work with the scanned models. You have to have 0 point. But that's a good question, because also in the software and during the recordings, there is possibility to check different relationship between upper and lower jaw. If you use different methods of bite registration or centric relation registrations or RP, whatever you call it, you can check it into the software, and we'll get back to that. Okay? Any more questions, guys? No? So we can go on. So here is an interface of the software when there is only axiography recorded. Do you see my cursor, actually? Do you see the mouse? Yes? Natalie, give me feedback, please. Do you see the mouse?
Yes, I can see
Okay.
it. I
Yes,
can see the mouse.
So we have here information about patient, and in diagnostics there's a drop-out menu here. So we have here axiography, position diagnostics that we'll discuss a little bit later. Central marker. So central marker is already recorded because when we press the button of the central marker, we have the information about the spatial inclination of the upper jaw. And for us, it's like a digital Facebook. So we have coordinates. Then we have computer tomography, 3D stand settings that we'll also cover a little bit later. And first, we have to add additional information into the software. One thing that we can't go without is the scanned models, because you can have axiography, but it's much easier when you can combine the axiography with the models per se. So we go to individual models, load, and then you'll have in the system the possibility to load upper and lower jaws. So you can load it in any file you want, PLY, OPG, STL, it doesn't matter. I like PLY more. If you use 3-shape scanner, somehow they usually like to give OBG or STL, so it's up to you. And then what we have to do, we have to give the models the spatial position inside the software. For that, we do the following. So we upload the upper model on the fork, and we combine it with the with a virtual fork, and then we can align the upper model with the model on a fork. So by doing that, we have here the spatial position of the upper and lower jaw. You can see that they are inclined. There is a candidate occlusal plane here that was not visible before. And also, if you noticed in this video, there is not a model, not a scan from the mouth. It is the only situation when I couldn't make the intraoral scanning with the fork because patient had very, very low frenum and patient has very low threshold, pain threshold. So it was the only time in my career, but I decided to show it when I just did the alginate impression, asked the technician to pour the model. We put on the model the fork with silicon material and scanned it. So it's also one of the options. For example, if you have already the models, the plastic models of the patient and want just to record axiography, you can also scan the models and upload them. But right now it's very rarely that we have to use this option. So we have the models right now. And next we have to upload, if we want, computer tomography. If you work with the radiologist, for example, you send the patient somewhere, it's better to instruct the center or the radiologist that, first of all, we need big field of view. It means 16 on 13, 17 on 20, 16 on 20, whatever. So we need to have chin, condyles, orbits, porion, and if you want, also the cervical spine. So it's preferable to have big field of view. And don't worry about the radiation load, because the bigger the field of view, the lower the resolution. So for example, in the dentists, when they use small field of view just to see all the MB2 or MB3 canals in the first upper molar, their resolution is the same as the resolution of the field of view 17 by 20. So the radiation dose is not changing. So only the details would change, and we don't need much details. We just need good quality CBCT. So when we have everything, we can go in the menu diagnostics, complex diagnostics, and we can create the diagnostics. So we will choose the data that we want to compare, align, or combine with each other. And here I'm ticking the boxes. For example, for my diagnostics, I need just computer tomography, I need individual models, of course, I need all the set of axiography, position diagnostics, and that's different registrations of different relationship between upper and lower jaw with the means of any registration method that you would like. Face scan. So I'm applying here everything. Just not to forget, I will write down how I will call this diagnostics. Usually, the nice advice is just to write down abbreviations of every data acquisition that you are using here. For example, CBCT plus models plus Axio plus FC plus PD, position diagnostics. But that's just an advice. And then you press OK, and the software will combine the diagnostics. So this is just a fast forward way, like I'm doing the diagnostics because I collaborate a lot with orthodontists. I'm doing cephalometric analysis, comprehensive cephalometric analysis that is required for orthodontists, so you can do that in the software. I do the X-ray analysis of the condyles, of the position of the lower jaw, and then I do analysis of the occlusion, and then I make the decisions about the therapeutic or diagnostic jaw position, about the settings of the articulator, and this information I will give further to the dental technician or to the orthodontist. If you just want to do simple dentistry, although it's not very proper example of the simple dentistry, but here we did this patient on a course, and this course was with Miloš Miladinov, who says that he wants just simple case. So what I did here, I arbitrarily just opened the bite here on trajectories. So what I mean by that? I mean that here we have the menu, which is like player, and here we have a slider, and this slider would start the movements of the lower jaw that we recorded. If I here have the menu option opened by trajectory, so, and I can write down, for example, 2 millimeters, 3 millimeters, 6 millimeters, whatever. It's my diagnostic or doctor's decision. I decided, for example, that I want to do the increase of the video vertical dimension of occlusion by 2 millimeters. How I made this decision based on some maybe calculations or DSD or whatever, it doesn't matter right now. It's my doctor's decision. So I can write down, open the range here by trajectory 2 millimeters, and now we'll have the opening that is not just invented by me or invented by the incisal pin and the articulator. I'll have the opening that the patient has and that we're recording during this test. And this is the information that I will give to the dental technician, because I can export this relationship between upper and lower jaw to the dental technician in STL file, and when he'll upload it in Exacut, for example, he will have exactly the same relationship in the Exacut meshes. And that's very easy. So dental technician already will have a space for his work. 3.5 may be too much, but that's I decided arbitrarily that I want to do that. So it was, for example, in Barcelona or something like that. And then we can export also the trajectories. And the difference of this system from any other system, that you can analyze whether the trajectories are good to be exported. Because sometimes you don't want to repeat what patient has, sometimes you want to correct it in the first place. But just imagine patient has beautiful trajectories, and we want to repeat these movements in the Exacut. So you can also export it as a separate file. It's XML coding, Exacut, Circunzan, Nemotech, InLab, they all are applicable with these codings. For InLab, actually, it's not coding, it's the special information to fill in the table that they have in the software. For those who work in InLab, they know what I'm talking about. So, and then dental technician can use his magic and do the workup. And then we can print the model, and we can do the try-in of the mockup, and we can do exography again. And I was mesmerized, really. If the dental technician is really good in making the workup, the virtual workup, and if the models were correct, we have extreme precision and accuracy. So this is just the axiography and the scans that were performed on the course without me grinding any contact. So no equilibration at all. And you can just see, just given information about the relationship between upper and lower jaw and certain height, and given information about the trajectories, I have extreme precision of the mock-up that I can try in the mouth. Although this is not a case for doing mock-ups, but I can tell you that patient was even mesmerized by the lower mock-ups. We couldn't do it on the upper because the tooth 1-1 was too much proclined, but the lower teeth, she was extremely pleased by the height, by the appearance, and she was very comfortable. So that's maybe 50–60% of your cases you'll do like that. You don't need even CBCT for that. You just need to decide the therapeutic or diagnostic position of the lower jaw, just have this information exported to the dental technician, and give the trajectories for the dental technician that he can use not with a virtual articulator, which is possible, but he can use it with a slider that will represent the movements when the dental technician would reach the level in the exocad where he has to work with the correction of the occlusal surface. And for exocad, you can ask Alkis later, you need just to have a jaw motion option, jaw motion module, and it's only two first steps that are different about how you upload information. The rest is the same workflow that you used to have in exocad, for example, in wizard mode or in any other modes. So there's nothing special in there. And you can have a look. So this is a...
Sorry, Leo,
yes.
can I ask you something?
Yes.
Do you prefer for your mock-up to do from the dental technician to print a digital WhatsApp and you make with a silicone key the mock-up in the mouth, or do you want for me to print a ready mock-up and all you have to do is to glue them to the teeth?
Good question. You know, I would prefer to have it, for example, what we call snap, yes? But
yeah,
I can tell you that I'm not that lucky to work with good technicians. So, unfortunately, the snap mockup is the best, but also not every technician is capable of producing it. Of course, it's much more precise if you can do snap mockup because you are not dependent on a silicone and you exclude the mistakes that could be done during the transferring of the silicone index into the oral cavity. But this was done with a silicone index. So technician printed the model, and I can tell you I was really impressed by the quality in Milos Menadilov lab. It was a keystone resin that we used in a spring ray printer. So it was like a plaster model. The precision and the detailing of the model is very nice because there was no striated surface. They used 50 microns as the thickness of the layer, and they did simple, not simple, but very nice high quality silicone index. If you can print snap-on, that's also very good. But sometimes you're not that lucky to have 3.5 millimeters of the opening. Sometimes you have opening maybe 0.5 millimeters and they'll be extremely thin. So it depends on the situation, as usual answer, you know. If you have enough thickness and the anatomy of the teeth can help you to make the snap-on mock-ups, I would prefer them because for me, it's the best for the selling and I can use them as temporaries. I can use them for many things. But if you couldn't do that because you're afraid they're too thin and you wouldn't be that precise, then normal silicone index just doctor has to be sure that he managed to put the silicone index in a very precise position. So, for example, one of the advice, just practical advice, but I think you all use it. I never put any mock-up on the last teeth, on upper and lower jaw. So second molars, always free from mock-up because I don't need them to check anything. And they'll be just the teeth for the support of the silicone index. That will make it more precise. It's not necessary for the upper jaw, but for the lower jaw, I think it's the only way to be precise. But it's up to you guys. But that's a very good question. Snap-on is for the best technicians like Alkis.
Thank you very much.
Thank you.
Can I ask something else?
Yes, of course.
I know it is just an example, but I would like to ask, to increase the vertical dimension, we cannot do it arbitrarily. We have some limits.
What kind of limits?
First of all, we have to record the rest position.
Okay.
So we find the between space at the premolars. Because we cannot increase it as much as we want.
Okay, so
I can for the markup, I understand that, and then we decide which is going upper or lower jaw. But as far as we don't have recorded the rest position at the system.
Okay, do you know the average numbers of rest position?
Yes, which is exactly the number.
Yes.
Excuse me, I mean the 3 millimeters.
Okay, so what is good about the software that it is not stuck to any philosophy. What you're talking about is one philosophy, which is very good, and you can use it. And for that, you can, for example, make this test. If you know how to recreate the rest position of the patient, you can do it during axiography. For example, Mississippi, Mama, lick your lips, you know, all the options.
I know.
Yeah. So, and you can make this test during the axiography. In that case, the only thing is that you have to ask the patient to do the first bite, and then you ask him to recreate any tests that you believe are about rest position. And then you can have this information in the software already, so you can give this information to the dental technician. I have different philosophy, so I don't use that. But if you like that, you can use it in the software. It doesn't matter. So the software is just a tool that you can bend to your philosophy, to your needs. It's up to you. There is no problem in that. Also, you can, as I told you, use bite registration methods, and you can digitize the bite that you have, I mean, the registered material, and the relationship between the upper and lower jaw with this bite. And you can also check the contacts, for example, in the software, and you can give this information to technicians. So if your philosophy is just opening the bites, for example, like Mauro Frediani says in his work, that until 5 millimeters between the incisors, it's completely normal to open the bite. Or if your philosophy is neuromuscular philosophy, when you have to make the tense, and then you have to record the myocentric position and find the GV point that is from the golden proportion, it's up to you. Actually, we just been in a clinic that specializes in neuromuscular dentistry, and we were recording the movements of twitching of the lower jaw during the tensing, and then we gave this information to the dental technician to produce a orthotic. So it's up to your philosophy. Or you can also use as articulator the condyles of the patient, because you have them in the software. So, and for that, you need to align the models with the CBCT that you uploaded also in the software. And one more comment about the CBCT, that please use it single file, DICOM file, but if it's multiple files, it's not a problem, but you will have one more step to upload. So I put 3 points, 1 point on incisor edge of the upper incisor closer to the midline, and 1 point on, for example, mesial buccal cusp of each molar on the right and left side. It can be the first molar, second molar, or even third molar. It depends on the quality of the CBCT. And right now, I have aligned position of the upper model with the CBCT. And that's the appearance, for example. Here we have, this is the OBG file of upper and lower jaw, and this is the CBCT. Actually, this is one of our dental technicians who work with us from Italy, and it's interesting because this is 1 gigabyte CBCT data, and I don't see any value in having this heavy computer tomography, because it is not better than any other. But here you see right now the models, the CBCT, and also we applied points. So everything in the software called is, when we do some kind of measurements, is called cephalometry. So, and basic cephalometrics, we need to align the models with the CBCT. For that, we put the points here, incisors, as I told you, prosthetic points, and that is the same, exactly the same points you repeat in applying on the scanned upper model, and that will help you to align. The point on the lower incisor will help us to locate the trajectories that will start from the lower incisor. The points on the joints will help us to have the trajectory starts from the top of the condyle head. And the point on the lower jaw here will help us to, what is the software called, detach or separate or segment the lower jaw in order to replicate the movements of the lower jaw according to the skull. So, and then what I like most, I like to analyze occlusion. And actually, this system, I think that it taught me more about occlusion than I knew before. Because, for example, guided movements, we analyze in case, from the point of view of premature contacts, from a point of view of the interferences, because we can see if there are any interferences, not in the final position of the lower jaw, but during the whole track, the whole movement. And guided movements, we will never give to the dental technician unless we're doing some simple conventional dentistry, like 3-mouth bridge, for example, free unit bridge or single crowns or whatever. So when we're doing what is called conformative treatment, when we're not changing the bite at all. Then the next is free movements, and free movements we can analyze just for the programming of the articulator or for giving information about the trajectories if we do like them. But just take notice, this is just normal patient, and I don't know whether technician would like to have these trajectories to be sent to him. So I think that every trajectory needs to be analyzed by the doctor. And we have here the condyle trajectories as well. So we have here the trajectories. The yellow one is a right condyle, the blue one is left condyle, and here we have the movements from the incisor ledge of the lower incisor. And also, if I don't trust artificial intelligence, which is actually very good, I can just decide what kind of move I want to take as information for the settings of the articulator. So you can have old-fashioned settings of the sagittal condyle inclination and Bennett angle. You can have them as AI analysis, when you don't have to think, you just press the button, or you can manually choose the path that you want to record in order to have customized settings of the articulator. So you can use it with analog articulator, or if your technician, for example, still used to have virtual articulator in this ExaCAD, for example, he can use it. But I don't see the point. Why should we see in the ExaCAD something that was restricted from the hardware standpoint, from the point of view of the metals and everything? But sometimes technicians are conservative and I like this appearance. And position diagnostics. So imagine that I use a wax plate here just to register some kind of repeatable position of the lower jaw when lower teeth are not in touch with upper teeth. So we excluded from the equation the teeth and we made the registration. And here is the difference between ICP and the bite registration that are made here. For example, this is first, this is second, ICP, wax plate. And we have here the difference and we can analyze it. And besides that, we can also do like we did before in the articulator. We can close to the first contact. Just imagine in the articulator, we had incisor pin, we have bite registration material between the upper and lower model. We remove the bite registration material, we have some kind of relationship between the upper and lower jaw, like here. Then we remove the incisal pin and close to the first contact. So we can do the same in the software. And so this is what we call 2D view. For those who studied Slavicek or who studied neuromuscular dentistry, this is a very familiar appearance. For those who don't want to do anything with that, you don't have to know that, but these are the condyle trajectories. One thing that it's better to know, so here we have maybe opening, maybe protrusion, and maybe lateral protrusion. So right now they're a complex trajectories. So they all together, we didn't divide them by one, but we can do that. So the closer all the trajectories to each other, the better are the movements, the better are the trajectories. So, and if there are no deviations here, it means also that the movements are quite good. There are no deviation, no any kind of different length of the condyle translation on right and left side. But so when we see here on the screen, when we go to the complex diagnostics, initially you have in the 3D views, this is a 3D view. We have here somewhere model because it's not aligned yet. We see trajectories, they're not aligned to the models. We see CBCT. Because here the eyes, the icons are highlighted. You don't need to put it on the screen at the same time. So you can press the eye, you can click on it, and you can hide anything from the screen. The one hint, don't hide computer tomography here. So make this eye always active. If you want to hide the computer tomography from the screen, here are the ranges, X, Y, Z. You can just close one of the ranges completely. So you move the slider from one side to the other until it will meet another slider, and you will hide the appearance from the screen. So that's how you choose what kind of information you want to have in the software. For example, what I'm doing right now, I'm analyzing the computer tomography, I'm putting the points, Here I'm putting the points on the CBCT, basic SDiMatrix, in order to align the CBCT data with the data of the intraoral scanning. And here I'm putting the points on the condyle head, so it will be the top of the condyle head in the middle. Then lower jaw for separation, and basic SDiMatrix analysis is finished. So you don't have to do every time the comprehensive SDiMatrix analysis for the orthodontic treatment or for any other means. So once again, you've seen this picture. So this is our technician, Tony. And here you see on the screen, we have position diagnostics is active, computer tomography is active, but axiography, we see only one test, not many, because there is not so many lines, and we don't see individual models. So they are hidden from the screen right now. And if you perform the so-called advanced SDiMatrix analysis, here is the menu that is appearing on the right side of the screen. And for example, why do you want to do that if you're not an orthodontist? Sometimes we prosthodontists require some kind of reference planes. And these reference planes could be Frankfurt horizontal, it could be Frankfurt horizontal, it could be Campra plane. We need sometimes occlusal plane and some other planes. For example, in Slavic philosophy, the idealized occlusal plane, Stomian is very popular, or there are many people who like hip plane or any other planes. So in order to put these planes, we have to put the points. And here we can use osteo and cutaneous points. And if you don't know them, you don't have to remember them by heart, because there is icon, I, so exclamation mark. If you click on it, you'll have the hint, the information where this point has to be set. And also here we have some options to calculate the bite height according to SDiMatrix analysis, if you believe in that. And you can also do the Shinbashi analysis if you use it in your practice. And you can do some exquisite SDiMatrix analysis like Kim analysis, which is, I think, very good, or Rokabada analysis for example, some kind of holistic way of treating the patient. So right now we can see here the planes that I made, and we can see what kind of reference we can use. For example, here the occlusal plane is more or less parallel to the Frankfurt horizontal, and Campra plane maybe is not the best for our patient. And bite height, so we can see here by the numbers that anatomically speaking, I'm allowed to increase the bite for this patient according to some philosophies once again. And here I'm using the X-ray mode in order to analyze in 3 cuts, X, Y, Z, the position of the condyle, the form of the and shape of the condyle head, and also the movements of the condyle according to the eminence and the glenoid fossa. So if you want, you can also see if the condyles are symmetrically positioned, or maybe one condyle is in front of the other, or one condyle is higher than the other. And you can measure the also the joint space if you believe also in the joint space analysis. Actually, in the new updated software, and I already seen it, there will be artificial intelligence analysis of the joint space. So we have the color map, and the green color will tells us that the joint space is like 3-4 millimeters. The blue will be like 2-3, and the red will be from 0 to 2, if I'm not mistaken. So you already will know if there is enough joint space or not. And analyzing joint space, you can also assume if there is a disc on a condyle, or maybe a disc already displaced. Sometimes it can be just a finding, maybe the patient doesn't have any complaints, but it's good information if you can know the problems of the condyles before you start your, for example, comprehensive rehabilitation of upper and lower dentition. And here I'm just detaching the lower jaw. So right now it's different color, it's a green color, and I can simulate the movements of the lower jaw that we recorded. So I can see the actual position of the condyle. So for me, my articulator is the condyle, not any metal part and nothing that I couldn't imagine. So only the condyle is what I will look if I want to make some kind of decisions about the therapeutic jaw position and about the diagnosis. So here you can just take notice that the trajectories are not that bad, but patient has deviation to the right side upon opening. So here I'm closing the range, and I can analyze the movements with the models right now. So this is my comprehensive analysis that I perform. So, and we will not go to it, but here, what I want to point out that this is slider. For example, if you want to analyze only one particular movement that you recorded, and I want to show you something here. Yes. So this slider helps you to just segment the movements. And just please remember this picture right now and try to answer in your head what shape it reminds you. And just in order for me to help you, because although they're interactive, I don't want to ask questions every time. Here we have a convex that goes to the concave shape and definitely convex shape that goes into the concave shape. And if also you take notice here, there is slight separation between the trajectories. So that is diagnostic information that you can either learn or you can neglect. It's up to you, but we'll talk about it later. This is how we segment the lower jaw once again. So there is a thing called prosthetic plane, and we can have different movements of the lower jaw. And then we do analysis once again. Here you can take notice. This is a patient that came for the prosthetic treatment, but we see the flattening of the condyle. And that could be some things that you might find and you might not expect it. So the patient doesn't have any complaints. The patient just want to have simple orthodontic treatment and then to have veneers, for example. But you can see that there are some features that tells us this joint had some problems in the past. And we don't know whether these problems would means something or not. And one more thing that I think is worth mentioning, that is the reason why I decided to insert this video. If you see here some strange trajectory, if we believe this trajectory, it means that the patient has immense problems with the condyle. But that emphasizes a very important thing. Doctor has to be present during the tests. So the system can just put the flags, put the camera, make this, maybe the bite registration on the fork, but doctor has to be present during the tests, because what has happened here is that the patient open mouth too wide and just lower flag in the end of the moment disappeared from the camera. That's why we have this crazy trajectory. And I've seen it, I noticed it during the test. So for me, it was not a surprise. If I wouldn't see that, and if I just work with the data, and if I didn't know what happened during the test, I might think that the patient has problems. So it's better to know it, and it's better to be very responsible during the axiography procedure. And just to show you the versatility of the system, because I don't know any other system of jaw tracking that is so easy to work with, because these flags are extremely light and it's extremely easy to fix them on every surface. For example, there are two extreme situations here. One is the patient with a dentulous jaw, and he has only the denture on the lower jaw. Actually, it's a medial denture. And so I am able to put a flag on the jaw, on the denture. Before that, of course, I rely on the denture on the silicone. And there is a patient with the braces here. So there is no jaw tracking device that can allow you to put something near the braces. But with this system, you can do that, because you can just apply that small flag on the tooth near the bracket, or you can just fix it on the arch wire. If you fix it on the arch wire, you just have to know that maybe in order to remove the flag, you'll have to remove the arch wire first from the brackets and then to put it back, because otherwise patient might feel some kind of discomfort. So I think that opens some new opportunities for us to make the recordings for the patients with the removable dentures that, for example, with in condylography, with the clutch that I had, was just impossible. You had to remove the denture. With the Mojo and Zebras, it's also impossible because I have clutch, which could not be put on a denture. And with neuromuscular dentistry, it's not possible also because I have a magnet that has to be put in the vestibulum. And if there is a denture, it covers the vestibulum, so the magnet just wouldn't stay there. So I think right now in the market, there is no other system that can provide you possibility to work with this kind of group of patients. And but these patients, they require a lot of prosthetic treatment. I mean, the patients with the dentular jaws, and of course, patients with braces, they'll be future prosthodontic patients, as we all know that. So, and once again, we are coming to the situation here that if you don't want to do anything else, yes, we can discuss that this patient is in desperate need of orthodontic treatment, maybe even orthodontic surgery, and maybe he is in need of some kind of occlusal spleen. It's not necessary to discuss right now. But what is necessary to see that if we want to have this jaw relationship exported to the dental technician, to the ExaCAD or any other CAD software, we can decide that we want to open the jaw according to the trajectory. And here I open it at 4 millimeters because you've seen the cephalometric analysis of this patient, and anatomically speaking, and taking into consideration that the bite height is decreased here, I'm allowed to open the space here between the upper and lower jaw. So hypothetically speaking, let's do it 4 millimeters. And what I'm doing right now, so it's here just for the sake of, you know, didactic purposes. That's not what I'm doing with the patient in reality, but here is a menu here. And in this menu, we have model export. I made a mistake here because it has to be upper and lower jaw and upper jaw on the stand. We have to tick this box for the ExaCAD, for example. I use reference plane horizontal. It can be a Frankfurt or Kemper if you want to. I use here as exported for the Ammann-Gilbert articulator, or you can just decide any other. And I decide to export it in this current relationship between upper and lower jaw. So that this information that would be received by the dental technician. And so some thoughts where you can use this information. For example, we are planning to extract all the teeth for this patient and to put implants. So, and I'm analyzing trajectories, and I wanted to do immediate loading here, but I don't want to do immediate loading just accommodating to the previous bite that the patient had. So according to the trajectories here right now, I see that when the patient is closing the mouth, her lower jaw is going a little bit forward. So I decided, okay, I might think about the forced position of the lower jaw. So I decided, why not to keep this position and to open the bite to certain height. Oh, sorry. Sorry, here. And I will export this information to the dental technician in order to produce the surgical guide, or maybe to also to produce the temporaries in the bite that I choose right now. So from the first hours of the immediate loading, I would have relationship between the jaws, not that was before if the patient problems, but the one I want to test during the osteointegration of the implants. You don't have to do that, but it's one of the third processes why we could need this kind of system, for example, for the patients with a terminal dentition when we plan to have immediate implant placement with immediate loading. And another situation what we can use also, so I'm here exporting this to the dental technician, once again, this patient with the dentulous jaws, where, for example, this was immediate denture. The bite here is completely wrong. Patient feels discomfort with using of this denture. And here we were planning trefoil, so free implants, and we plan to have a final titanium bar that will be realigned into these prostheses. So the doctor who was managing this patient asked me to help him with the bite registration. And every test we performed were not good because patient just could not properly move his lower jaw and close the mouth in a repeatable position. But then he started counting, and when he was saying 77, 78, 79, I here managed to catch this position of initial starting point of the pronunciation of the S sound. And I gave this relationship to the doctor and told him you have to make some kind of jig or walk stream in this position in order to verify this relationship between the regions. So that's what he did afterwards. So that could be also of great assistance to make the bite registration or the, let's say, inter-reach registration for the dentulous patients, if they have old dentures, even of the low quality. And so this is what we see. These are the trajectories that in the condyle. So this is 2D view. You don't have to live here, but I prefer to live here because of my education, because by my education, I was doing a lot of condylography, as I told you before. So we can analyze here the shape, we can analyze the quantity, the quality, if there is, for example, some kind of movement that is maybe a little bit twitchy, there is no smoothness in the movement. We can analyze some special findings like the cross that could be the feature of the click. We can analyze if there is separation between excursive and incursive movements. So that definitely tells us about the muscle problems. So many things we can analyze here. And if you think, wow, it's very complicated, I will never be able to understand these trajectories, let me help you. This is just a crash course in gnathology. I'm sure you all know that, but just repeating is not a problem. So here is the condyle, and here is this disc, and here is the distal slope of the eminence and glenoid fossa. We have retrodiscal lamina here. So everything that you know already. So I don't want to to humiliate you with this knowledge, but I think that we can discuss it from the point of view of the picture. So when the condyle is moving, we know that there is rotation first, but actually with axiography, you'll see that not all the joints start with a rotation. Many of them start just directly with translation, but it's for another lecture. So when we have the movement, when the rotation is already finished, we have translation, and there is just a movement of this complex of disc and condyle according of the eminence here. So we see that if we try to make the drawing, we can make the convex line, convex trajectory. So in case of the health, if there is disc on the condyle, if the eminence is not flattened, it has nice distal slope, so we'll have the convex shape of the trajectory of the condyle when it's moving. But for example, remember, I ask you to remember our patient from Italy, our technician. He had what is called first convex and then concave shape. I was still on convex, no, concave shape, I'm sorry. This is concave shape. So concave shape of the trajectory is what is representative of the good trajectories. So our patient has first convex and then concave shape. What it can tell us, one of the features that it could be that a disc might be in front of the condyle, or condyle might be distal from the disc. It's semantics, I know, but sometimes it's very important for the diagnosis. So first we see that the condyle is doing the movement according to this concave shape of the glenoid fossa. And we see as a negative representation of that the convex shape of the trajectory. And then the condyle will translate to its more appropriate position according to the eminence. And then we'll see the concave shape. So that's how can we analyze the shape of the trajectories in our software. Just remember this picture. And just imagine that there is no disc, and the condyle and eminence were rubbing along each other for many years. And of course, they became flattened, this kind of osteoarthritic changes that not necessarily will be accompanied by any pain. That will be the premature changes of the condyle that are just modeling and accommodation to some kind of changes that occurred in the condyle. So it's the condyle, the TMJ is still in adapted mode. And it could live like that for the rest of the life of the patient, but maybe we'll do some kind of dental treatment that will put the patient in a disadaptation. So it's very good to know that before you do any dental treatment, what is the condition of the TMJ. You don't have to tell to the patient, oh, your TMJ is sick, you have to find treatment for that. No, you can inform patient, you have this kind of shape of the condyle, you have maybe this kind of situation in the TMJ, and you have to be informed about that. And maybe what we'll decide that we'll wear the temporaries, for example, longer than we planned, not 2 weeks, but let's use the temporaries, maybe mock-ups for several months, just to be sure that whatever we're doing with you right now will not cause any problems in the future. So we will be more careful in performing our treatment. So if the eminence is flattened and the condyle is flattened, we'll have straight trajectory, not any concave shape. So that also pathognomic for some kind of arthritic changes inside the joint.
Can I ask you something on that?
Yes, of course.
All these jaw movements that you show us, with the condyle and the disc, you don't have a starting point. You just have movements.
Yes.
And that's what you want when you collect data.
What do you mean? What is starting point for you?
Usually what I learned is the hinge axis.
Okay, you can use hinge axis here. But tell me, why do you need hinge axis? What is hinge axis?
Because it is the most repeatable position.
Who told you that?
Movement.
Who told you that?
Open and close. You don't have movement. The
Who told you that it's most repeatable position?
And the theories.
Okay, but also read another theory. Do you know the distance between the centric relation of RCP and MIP in the condyle? Do you know the actual number of this distance?
No, I don't.
0.3 millimeters. That's a science. So if we go in this semantic, you can use reference position, but I can tell you that it's very hard for the patient to hold in reference position because I was doing condylography on me and I was working in reference position. And I can just share with you my opinion. That's not any official opinion, okay? And if you tell me that later that I told you that, I will deny that. But what is reference position? Or what is hinge axis? Hinge axis was representation of our limits in the 70s. Imagine in the 70s, there was no CT. If you want to see the condyle, to visualize it, we have to send the patient to the medical CT, which is quite a big radiation dose. We had a metal articulator, yes, with a metal hinge axis and a metal jaw balls, ball and socket.
Yeah.
We had patient, and we didn't know what was inside his joints. And we wanted to record the movements. So we need some kind of translation language, like interpretation between the patient, between the cephalometric analysis, and between their frame of the articulator. So we invented some kind of reference planes for us. Yes, the first was the Frankfurt plane, before that was others, then was Kemper plane. So axis orbital plane, for example, that helps you to locate the axis of the rotation of the joint. And if you remember in the 70s, they did the tattoo on the skin because they found this.
The Bexton point.
Yeah. And then it turned out that it changes with life. So that was because we didn't know better. We could not recreate any movements of the jaw, first of all. Second, we didn't see the condyles. And third, we were using the metal articulator with its limitations because it could never recreate complexity of the movements of the patient's lower jaw. So if you believe in reference plane, then we will be working still in a way like we don't have today's technology. We don't have scanning, we don't have CBCT, we don't have complete recreation of the movements. And system will not stop you with that. If you want to do that, you can make the reference the hinge axis evaluation. You can use the bite registration. You can do all your movements from this position if you want. Now, nobody will stop you in that. But I can tell you that by the science that I know, this is already quite obsolete because even if we talk about neuromuscular dentistry, another science tells us that this myocentric position that is so forward, yes, it's 0.5 millimeters from the ICP position of the condyle. Just imagine what is 0.3 millimeters of the RCP and MIP slide that we have in the patient. And you'll see that in the condyle, that's maybe some kind of level of error that can be, nothing more. But if you think that's right, what I recommend to you, you can compare, you can do with your patient the registration of the axiography from ICP, and then you can repeat the same with the hinge axis position that you defined. And then you can just compare in the system the trajectories, the condyle position, and the lower jaw position. The system can help you to have answer for your question, because in the system you can compare anything you want. And you'll be surprised that you'll see that there is not much difference in the condyle head position in the hinge axis and MIP position.
I was going to ask that. Will I find any differences?
Yes, so you can do that. The software can help you get the answer because you're not forced with this software and this axiography to do like we tell you to work. No way. If you were taught to work like that, you have good results. So this system will just maybe ease up some steps for you. It will make some steps easier and will make the communication with technician more productive. But if you want to just to check, maybe something that you were taught before was based on the limitations of the science per se and limitations of our technology, maybe we don't need to use it anymore. You know, it's up to you. But that is very good question because I hear all the time about hinge access. I wasn't, a hinge access guy myself. But I remember one thing, that when I was doing condylography on myself, and when a doctor who was performing condylography on me was telling me, don't see what he was finding the rotation, and I had to hold the lower jaw in this position where there was only rotation. In several minutes, I was dead completely. That is not repeatable for me. I could not relate to this position. So I wanted to bite because when I closed my mouth in MIP, that was something I can relate to. So I would tell you that hinge access recordings could be influenced by the patient you're working with. Sometimes it's so hard to work with a patient whose jaw is not stable because of the muscle problems or some other things that you might be mistaken. If you ever perform condylography, many times, many experienced doctors do what is called refix. So they lose hinge access and redefine it again, refix. And then you see the condylography, you don't understand what is going on the screen. It doesn't make sense for you. So
I am 100% with you. I don't believe in hinge access because if I do it 100 times, I will find different hinge access.
Absolutely.
But
so
the theory, that's why we must have a starting point. That's sometimes.
So for us, the easiest starting point is MIP. It doesn't necessarily have to be the right point. No way. It could be absolutely wrong position of the lower jaw, but at least during the test, you can repeat it anytime you want. And then you can decide from that position where you want to move the lower jaw. And at the same time, this is the easiest thing to record with the intraoral scanner. And besides that, hinge access could be used on articulators. But right now, I have the opinion, we have new CAD softwares that can, for CAD software, articulator is something from the past. They could recreate any movement of the lower jaw that we record. So why should we limit ourselves with hinge access? Then ExaCAD can reproduce anything. And it means that when we have recordings of all the chewing cycles, all the movements, ExaCAD can just check the occlusal surfaces according to these movements. Not like we can also use the incisal table and have only this angle of inclination and check. That is limiting. And in my practice, I never delivered any crown without me making a calibration in a lateral protrusion and protrusion of the patient. Technicians never were precise in that, or they did it in preclusion. In that case, it can be very precise, but I can be very, very precise in ICP, yes, if the technician is good, but I was always equilibrating any excursive movements on the crowns, and never they were precise, no matter what kind of methods I was using. So, but that's a very good question, because I emphasize all the time, this is not a system for you to master the philosophy. This is a tool for you to master your own philosophy and to practice it. So nothing more. So you practice it, you try it, you compare it, and you'll see. I'm sure about that. So here I am using the technology. You see, it's very good when sagittal, but when it has transversal problems, and it's just patient just after the orthodontic treatment who came to me to do veneers. Just imagine how should I feel just to make the veneers for this patient with these kind of crazy movements that we see. So, and that is one thing that I want to show you. Neuromuscular dentists, you work with jaw tracking device, which is K7 or Meyer Research, Bayer Research, I don't remember exactly. So, and this is very complicated hardware that was not updated for many decades. So they work in what is called velocity here. So velocity is the language understood by a neuromuscular dentist. So I don't know it, I don't use it, but as Javier Vasquez explained to me, the same patient, so this is a velocity, so patient very quickly opens his mouth because his occlusion is not comfortable for him, then he opens his mouth wide and there is a first click because of some internal disc problems, so internal derangements, then patient starts to close his mouth and see the second click, and then the patient decreases the speed of closing because this is not his comfortable position, and in order not to hit of lower teeth with the upper teeth with a great speed and traumatize the teeth, patient decreases the speed before the ICP. That, if it makes sense for you, use this. So it's up to your philosophy, but the software has all the possibility from basic to most advanced and comprehensive to use the data. So once again, we see these movements, how the patient opens and closes, and that's exactly the same movements that we've seen in normal for us picture with opening and closing. And I will just speed it up a little bit. And once again, this is the same patient, the same movements. It's just up to you what part of the software is more familiar for you to be more familiar with and more acquainted with the information that you receive.
Can I ask something on that?
Yes.
From your experience and your knowledge,
yes,
and from your both specialties, which occlusal scheme do you prefer at the lateral movements?
Good question. If I'm doing the scheme, yes, so I'm doing the prosthetics or I'm doing orthodontic treatment, or I would say I'm taking the result from the orthodontist, yes, I have to verify it. I prefer usual occlusal scheme, yeah, canine guidance, anterior guidance, and disclusion of posterior teeth. So for me, because we don't know better, we have to do something that was verified and checked for many years. But if the patient comes to me without any problems, without any complaints, and I see class 2, maybe edge to edge, or I see open bite or any other malocclusion, I would not tell the patient that he has to correct his bite because he would definitely have the problem in the future, or that his malocclusion is very bad for his joints or whatever. I don't believe in that, because there is a thing called dental history. So from the age of 12 years, patient has his dentition, his permanent dentition. And if we see the patient in the age of 40 with not any carious lesion, with the physiological wearing of the teeth, so there is no dentin exposed, teeth are in good anatomical shape, and he is crazy bite, I am not allowed to tell to the patient, no, if you change your bite right now, you'll have problems, because he had not. His 28 years of experience of living with this bite just proved that this occlusion is quite good for him. But if the patient had, like, for example, class 2, division 1, with overjet 11 millimeters, and I ask the orthodontist to make the correction, and orthodontist makes edge-to-edge position with overjet just 5 millimeters, so it's much better than before, but it's not our class 1 occlusal concept. And orthodontists will tell me, like I usually hear from many on the congresses, well, it's not the best result, but it's definitely much better than it was initially. I would not accept this result, because I don't know how this patient would live with the edge-to-edge class 2 occlusion with this overjet, because he doesn't have dental history. And that might be the occlusion that will give him disadaptation. So for me, occlusal scheme, if I have to produce it, for example, on implants, the only difference is that I suffered when I did nice, good overbite on implants like 4 millimeters. Unfortunately, it doesn't stand that way. Overbite with the implants, total rehabilitation has to be no more than maybe 3 millimeters. I've read it somewhere, but that's just my experience, that unfortunately, especially if we do hybrid prosthesis, that could be problems of chipping and or debonding of the teeth if there is acrylic teeth on one of the jaws. But and I also would like to see immediate disocclusion of posterior teeth. There was a dental technician, a very famous guy named Masahiro Kawata, and he had a book. He was a dental technician, so he had a book about occlusal concepts for dental technicians. And I really advise you to try to get acquainted with this book, because he had a concept which was called FDO, functional disoccluded occlusion. I think that's one of the most appropriate, easiest to replicate, and the most logical occlusional concepts that ever existed in the world. So that's my idea.
Thank you.
And I want I want to show you one clinical case. Let me, oh, it's okay. We can go here. So that I will do quickly. Just you know, it's very interesting. You asked about the occlusal concept just in right time of the presentation. Maybe I was logical, and maybe this question was in the air. So that is the patient that was sent to me by orthodontist, my wife. So she's very strict. In order for me to, I would say, make her to give her permission to debond the braces. So the patient is okay. He had like class 2 division 1. He had very big overjet. Right now it's class 1 occlusion on canine and molars, and usually overbite 2 millimeters or 4 millimeters, overjet 2-4 millimeters, class 1 occlusion is everything that orthodontist desires in order to just debond the braces. But just take notice here, when the patient closes mouth, and you see where the first contact is. So it's palatal cusp of the first molar on the right, on the left side. So it's like a T-scan, but without the pressure measurement. But we see in time that the first contact is here. Maybe if the patient would have this bite from the age of 12, I could say it's okay, but I don't want to leave this premature contact, this initial contact, for the patient who just finishes his orthodontic treatment. So if we go further and see what is happening next, so this is this contact that is first enclosure. And then we do some other movements, and we see that gradually the contacts appear. So what we do next, we have to analyze some other movements. And right now, let's see their protrusion. So the patient goes into protrusion, and what we see during the protrusion, so this is a guided movement. Remember, these teeth are sliding according to each other. There is no opening here. And look, in protrusion, we see that palatal cusps of the molars on the right side are not releasing. So this is interference. Interference that is not very good. That could be a torque problem, because that's usually the problem with the second molars, because the palatal cusp is hanging after the orthodontic treatment. And it's not very good, because by some theories, not by every theory, but some theories, if the posterior teeth are not disoccluding during the excursive movements of the lower jaw, the muscles could not relax. And so we have to provide for the patient the best. And then the patient goes into complete protrusion. So, and we see here that there is a contact on the buccal cusp of the premolars. And I don't like this premolar, because I don't like that it always interfering with every movement. So I asked the orthodontist, what was with this premolar that it's in such a bad position? And I found out that the previous premolar here was used the cross elastics. So the torque, the buccal inclination of this premolar is not very good. So it has to be changed, it has to be corrected before the braces would be debonded, because otherwise you see that there is avoidance pattern from this premolar, that lower jaw goes sideways in order not to have this contact. This is the contact that the patient doesn't like unconsciously. And then we have also here the contact and canine and premolar in the final excursion. So no, that is not interesting for me. The final position is not so interesting. The way to this final position, that is more and more important for our patients. And we see here that on premolar, there is the pressure is more. So if the canine that has pointy tip would be worn in the future, we'll have all the guidance only on this premolar tooth. And if the root is staying closer to the buccal cortical plane, it means that this tooth will be prone to recession here, because it's not very nice buccal inclination. And at the same time, there is a lateral load on this tooth in excursive movements. So that is not also very good. So we go further, and let's do and see what is going on in lateral protrusion. In lateral protrusion, we see that there is interference on the non-working side. By many books, it's considered to be the sin to leave this interference and not correct it. So we definitely know that the treatment is not finished, that orthodontist has to work with the torque of this premolar. Otherwise, there'll be a lot of problems here. So we go further and we see that this premolar is definitely not good. And once again, we see here the palatal cusp of the second molar on the right side that is not releasing. So, and that is something that I have to give. And when we go to the left, to the right side, lateral retrusion, we see here that besides canine, there is still contact on the palatal cusps of the first and second molar, which is, by some theories, once again, the predisposition for some muscles problem that the patient might experience. So that's what I believe in, that if we want to finish the orthodontic treatment, we don't know better right now. We have to give the patient the best occlusal concepts that is documented in the textbooks, because patient doesn't have history and we don't know what kind of prematures or interferences, how they will affect his future function.
Can I ask something on that?
Yes, of course.
The recordings that you did at this case, the orthodontic case, you repeated that or only the initial ones before the orthodontic treatment?
Before the orthodontic treatment, I didn't have the device yet.
Okay.
So you're absolutely right. And actually, one thing that I want to clarify maybe here, that I think, that's my opinion, that we have to do this examination at least 3 times during our course of working with the patient. So initial acquisition of data, so as initial data collection procedure, after the mock-up, with a mock-up, or after the orthodontic treatment, or on a temporary on implants, so in some kind of temporary mode, and after the delivery of final result. And then we can compare, and we can have also some kind of answers what we are seeing, because the information is good when you can compare it. So, for example, the trajectories that you record for the mock-up might not be very precise, but when you had mock-up in the mouth and you like it, so these trajectories that will give the dental technician will be 100% precise, and if you like them, you can replicate them in the final result. So that's a good question. Thank you.
Yes.
So one thing I want to show you what is here. Let me see. That is digital variator. I don't want to elaborate on that right now because this is what I call 18 plus or 21 plus. That is when you can decide the position of the lower jaw not based on trajectories recorded, but based, for example, your philosophy about the joint. And this is nothing to do with the patient's abilities. For example, there is philosophy of distraction splints, and you can program the position of the condyles and the position of the lower jaw in this part of the software. But that is only for those doctors who work with this philosophy. That is not for average dental work. So I don't want to elaborate on that, but so it's also one of the possibilities what kind of information we wanted to give to the patient. So once again, we have this position and we decide, for example, but it's arbitrary. It's not something the patient has. So initial coordinates, Exacat, Nematec, Circumzanine, Lab, Ceramil, we use Exacat, and a horizontal plane, and this current position that we can export to the dental technician. That's one of these cases when the patient just came for the aesthetics, and she is completely asymmetrical. So there is no part of her skull that is symmetrical, or at least I would say close to symmetry, because there is no such thing as symmetry. And she doesn't have functional complaints, but she had a very severe problem with a Kent of occlusal plane, and she had before orthodontic treatment with extraction of 2 premolars on the upper jaw. And so she came to orthodontist, but orthodontist sent her to me. And this is one of the situations, because there are a lot of doctors who argue that when a patient looks himself or herself in the mirror in the eyes, you could not register the position of the head according to the horizon. I don't know that, because according to COIS and according to many, many studies, 90% of cases when a patient looks herself or himself in the mirror, he aligns his head according, or aligns the interpupillar line according to the horizon. So here I'm using the face bow and frame, and I use on the horizontal level this bubble. So I ask the patient to put the olives inside the ears. I ask the patient to turn her head in a way that the bubble would be in the center, so not to adjust the frame, but to adjust her head. And when she is doing that, I'm pressing the button of the central marker. So I have the position of definitely horizontally aligned head, if I want to use it as my digital Facebook, for example, for the work. And then I can work with a condyle here, and I use digital variety here, not to do any splint for treatment. I do the splint for checking. I know that in this position, I could not produce any aesthetic result. And I'm thinking there is no joint here. There was some kind of orthotic changes. So the right condyle is completely gone. It's remodeled. It's very small. The left condyle is a bit bigger. And because of that, we have the movement of the lower jaw to the right and upward. So in my variator mode, I just arbitrarily decide that I want to distract the right condyle on 2 millimeters, compensatory distraction of the left condyle on 1 millimeter, and I want to make the also here the coincidence of the midlines between upper and lower jaw. So that's my wishful thinking. I don't know whether I would succeed in it or not. So I have to check it before I would say anything to the patient. Is it possible or not to treat her? So I give this information to dental technician, and then dental technician will use this information in order to produce the positioning splint. So this positioning splint for me would be the test drive before even should pay for the mock-up, which I have to judge because technician has to charge for it too. So I want to do something very simple, very cheap, and something that can be easily discarded if the patient would feel any complaint. So I'm doing this kind of positioning splint. And here, technician is using the information. And also, I asked the technician to use the trajectories analysis, although it does not need it here, but just for the sake of showing it to you. So technician is adjusting the contacts according to the trajectories that I've sent to him and the trajectories that he is using in the Exacut with this slider that helps you to reproduce these movements of the lower jaw. So his work is finished, and then I can try on, and you can see initially what kind of veneers or what kind of crowns you can do here if you have this kind of inclination of the upper jaw and if the lower jaw is also inclined like that. So what I'm doing here, because I don't know, there are some chiropractors that can also align the upper jaw, but it's not the case here. So what I'm doing here, I'm testing this splint. And you see with the splint right now here, I have the coincidence of the midline. I have space which is different between the teeth on the right side and the teeth on the left side. If the patient would say she feels okay, if nothing is happening and she feels fine, I can send her to the orthodontist, and we can do using this splint, and we can actually convert it into the mock-up, something fixed. We can do extrusion of these teeth, gradually grinding the mock-up on the right side, keeping the contacts on the left side, and by doing that, I will be able to correct the count of the upper jaw. And that will help me to have a good aesthetic results after the orthodontic treatment. So, and just to be sure that she can really function with this splint, so that's how she functions on the 3rd day after the delivery of the splint. So she doesn't have any complaints, but I want to wait a little bit more because we open the space in the joint. I want to see the radiological findings of the changes of the condyle head before I will go on with her treatment. And I'm doing also here axiography with the splint, just to be sure that whatever trajectory she has, they don't get worse. So I can compare the position of the initial lower jaw position according to the upper jaw, and I can compare it with the position with this splint. And I can also compare here with the trajectories that we have here. So I think that when a patient goes for aesthetics, we always say, oh, it's aesthetics, it's not function. To be sure that you can do aesthetic results for the patient, you have to check function. And that's a device that can really help you to do that. So,
Leo, can I ask you something?
Yes.
I have asked you that before, but I want you to explain it to us once again. Why did you choose to make the guide splint in the lower jaw, not in the upper jaw?
Just because I used to do that. There was no scientific explanation for that at all. There are as much literature about the upper splints as about lower splints. It's just a matter of convenience and a matter of habit, nothing more.
Okay, thank you.
There is no other explanation, trust me. There is, if somebody would tell you scientifically, well, because of that and that, no, everything could be disproved.
Okay.
Because, you know, if I want a patient to use the splint more, upper splint, I had problems that patients stopped wearing because of the aesthetic problems and because of the discomfort. With lower jaw, it's a little bit easier. And aesthetically speaking, patient can smile, can talk, and sometimes the splints are not even visible. That's the only explanation. Also, what you can do with the system, if you want to stay analog, for example, in the final stages of the implant rehabilitation, sometimes you need physical model. So you can have this, according to the center mark recordings, you can find in the 3D stand settings, the map. There is a stand in the kit with a special metal inserts that can be adjusted according to their length. And you have here the guidelines how to use it. For example, if you use horizontal, so that's how you use it. So you use this information, you rotate these pins to the certain height that is written here, you place them in the sockets that are numbered in the plate, and you connect it with the upper plate. And so you have your own mounting table for the mounting of the physical model in the articulator. Just warn your technician that these models, these forks will seem too distal in the articulator because of this anatomical features of the fork itself. But if you measure the distance from the upper anterior teeth to the condyles of the articulator, you'll see that the distance is quite okay. It's in an average range like 110 millimeters. For example, or you can have different settings. If you don't use horizon, if you use, for example, the Frankfurt plane, there'll be different, slightly different mounting. And you can order it if you use Amann earbud or other articulators, so we can order it. So, and I want in the end just to show you one clinical case, and I think that will be it for you because I think you had enough. Just, I think judging by my accent, you can tell that I have a Russian origin, and you're absolutely right. I was proudly considered myself Russian dentist until recently. And right now, I'm positioning myself as Israeli dentist. But there are good people in Russia that started to take a lot of antidepressants since the beginning of the year. And you know that one of the side effects of the antidepressants is the bruxism. The grinding and clenching becomes even more for the patient. Now, this young patient of 24 years of age, he came to me with the complaints that his teeth are becoming shorter, and he sees it in the mirror. Usually the worn-out dentition, the wearing of the teeth is not visible for the patients because it's a gradual change that takes years. And so it's like, you know, when we have changed the appearance only by looking at the photos made 20 years ago, we can say, oh, I was different by then, but you can't see it in the mirror. So, but he was noticing that his teeth are getting shorter. And so he came to me with a wish to make veneers on his 4 incisors. And what you can see here is that, well, it's a good-looking young man, 23 or 24 years, and I see that his teeth are shortened. But, you know, also I see that there was wear facets on his lower teeth, and we see that there were no more cusps on the canine. So if we talk about his occlusion, we see that's class 2-ish occlusion, where there is missing first molar on the right side with the mesial drift of the second molar on the right side. We see the small diastema. We see proclination of the upper and lower anterior teeth, and we see crowding on the lower teeth. So I here have the case where if I want to do veneers, I have to make sure that his smile would not get worse. Also here I can see wear facets. And these wear facets, if you read John Coy's work, are very, very close to what he described as constricted chewing pattern. So it means that upper teeth are interfering with the envelope of function during the chewing. So before these kind of devices were in our armamentarium, we can always believe John Coy's. By analyzing the wear facets, we can make these diagnoses. Right now, we can prove it with this device. So, and I'm doing my normal conventional aesthetic analysis because I want to make his teeth longer. They're really quite short. So I decide that I have to elongate them. And also I see that the proclination is quite big. So if I just want to do no prep or minimal prep veneers, I will even make this inclination worse. And I know that when there is too much proclination of the upper incisors, and if there's angle more than 90 degrees according to the camber plane, the reflection of the light of these teeth would not be favorable for the aesthetics. So although the teeth might be prettier, it will not be visible because it will not be so nicely position according to the light that will fall on these teeth. So, and I decide that in my philosophy, because I want to keep the certain range of the overbite, because I want to increase the length of the upper and lower teeth, I have to increase the VDO, vertical dimension of occlusion, and 2 millimeters. Here is a mistake. It was 1.5, but after that I decided that I want to do 2. So this information is received by the dental technician, how I expect him to elongate upper and lower anterior teeth. So it will be elongation only to the incisal edge. I don't want to change the position of the gingival margin, and I don't want to touch posterior teeth because his posterior teeth are in pretty good shape. So, and I want to increase the VDO. But before that, just I would ask the technician to raise the incisal pin. I will try to catch this position with some bite registration material. But here I'm using the software to analyze these, and I'm using the software to analyze his occlusion to make the measurements, for example, of the teeth. So I don't need any other software for that. And I have all the necessary data right now also for the orthodontist, because as you might understand, I decided that I want to change the proclination, not by aggressive preparation, but I want to change proclination of the upper teeth by orthodontic movement. So, and anatomically speaking, I'm allowed to open the bite to make the bite higher. So on my treatment plan is that I want to upright the upper and lower teeth. I want to align the lower teeth. I want to open the space for the implant in the position of the tooth 1-6. And so this software helps me to do all these decisions. And then what I can do is I can give all this information, so I can analyze the joints, everything that we've seen before. And I also can give the information about so this system still analyzing the chewing, everything. So that is this 2 millimeters, for example, that I want to replicate. Once again, here I can convince the patient that he has the constricted chewing pattern, because we'll see the chewing in the next, I think. Yes. And if the patient says, why should I have orthodontic treatment? Why can't you do veneers like a doctor across the street who offered it to me? You can just show this picture to the patient and tell him, look, that is how you chew. That will not be changed with my veneers. So it only means that whatever I will do to elongate your teeth, either you will have more forced position of the lower jaw. In that case, you'll have problems with the condyles, but my veneers would be safe. That's a bad scenario. Or my veneers would crack, but you'll have a healthy joint because your lower jaw would just find again the freedom by cracking the restorations I would fix on the upper teeth. That will be the best case scenario for your health, not for my veneers. So the patient sees all that, and right now we have the proof of the constricted chewing pattern that he has. So if he has a constricted chewing pattern, one of the treatments is to increase the vertical dimension of occlusion, because by default, the lower jaw will do the clockwise rotation and go a little bit backwards. So during the chewing, the envelope of function would not be here restricted by the upper teeth. And besides doing the orthodontic treatment and moving the teeth, we can just upright and a little bit retract the lower teeth in order to not have problems with this envelope of function. So that's what I decide here, what kind of jaw relation I want to give to the technician. So it's 2 millimeters that I opened according to the trajectory. So, and technician will get this information for ExaCut and will use this information. So what I want to do, my idea is that I don't want orthodontists to guess what kind of shape of the teeth would be after the orthodontic treatment. So I want first to make the design of the anterior teeth of upper and lower jaw. I want to try it in the mouth. I want to open the space between posterior teeth by opening the video. And then I will send the patient to the orthodontist. So orthodontist will close the space between a posterior teeth, that is occlusion by orthodontic means. At the same time, orthodontist will see the final shape of the teeth that I want to recreate, for example, in ceramics, and orthodontist would not guess during the work. So orthodontist would place the teeth accordingly. So my preparation will be minimal, or maybe there will be no need for preparation at all, just to remove the composite that will be used during the orthodontic treatment. So that's what technician is doing right now. So he is making here 12 walks-up or 12 mock-up, and this is the first steps of working with Exacut with jaw motion, when you use a Prosthodontist and you just align. So this is the relationship of the models you get. So this is what technician sees, and that's how he can check the movements of the lower jaw in the slider. So, and that's very straightforward. So we can have a look. The technician is doing his magic. I think it's quite familiar for you. And I give specific instructions. Besides the length and the width, the height and the width, I'm telling technician not to correct the rotation of the canine, just to make it the same. And also I asked him not to correct the crowding by his mock-up. I want the crowding remain, just the teeth to be higher, and that's it. So I want to keep the malocclusion, but I want to change the shape and to give the final shape of the teeth to the patient before he will undergo the orthodontic treatment. So the rest is quite a normal range of work, and we can once again look. I told him, if you have premature contacts, don't try to correct them, because it's impossible. That will be corrected by orthodontic means, not by the means of the prosthetics. But the patient sees also, and I see, and the technician sees where these points are, so I can check my precision in my work. So that's a mock-up I'm trying, and I have to tell you, I'm not that lucky to work in this clinic with good technicians. So he prints pretty shitty model. And what I do, because he wants to speed up the process, and he makes 100 microns of the layer, which is not good for this resin, but I didn't know that. So I found out that much later. But what I'm doing intergenite impression. I'm carving the plaster model, and I'm doing here injection molding technique. And that's how I will make these teeth higher, longer. So I'm doing injection molding technique of the upper jaw and for the lower jaw. And that's how I can let patient go. But the thing is, you see, it's exactly the same contacts that we've seen in Exacut when technician was verifying their contacts. So they stay the same. And we have here this occlusion. If I would just let patient go, actually, there were a lot of scientific work that tells me that by the force of his mastication muscles, the teeth will come into the occlusion, which I don't want. I want to raise the bite height. So I'm doing for the patient the so-called retainers until the patient's aligners would be ready for him to start wearing them. And that's a treatment plan from the orthodontist. So everything we discussed, that uprighting and opening the space for the implant, the lining of the lower teeth, and it's all done according to the shape that I managed to create with the help of the software by giving a certain instructions to the dental technician. And so I think that for today, I plan to show you a lot, but I think that, guys, it's too much for today. Maybe we'll meet again. So I'm ready to answer your questions if you have any, because the webinar officially is finished. Hello, is there anybody out there?
Hello. Thank you so much for the presentation, and I would like to ask participants, if you have any questions, you are welcome to ask.
No, not for me.
No, I think you did a great presentation there, Leo. So nobody has any questions.
Or nobody understood, but what I want to say in final remarks is that, this system is addictive, because when you start doing exography, the work with the hardware is very easy. Trust me, it just takes one time to show it to you, and you'll be able to do it by yourself. The work with the software, it might be tricky in the beginning because it's just a matter of habit. But fortunately, there is a support team in the company that will guide you for first maybe 3 months, or if you want half a year, with every case that you have, they will help you what button to push, where to click, what to do next. And then just analyzing the data in the software will expand your knowledge about your patient. That I'm sure of. And I'm sure that the axiography will be standard of care in every dental clinic. It's just a matter who will start doing it first. Like with the CBCT and intraoral scanning, nobody believes that it will be so popular as we see it right now. So I'm sure about that. So take your pleasure and fun in using this technology, because it's real fun, trust me. And I wish you good luck in mastering this technology. And I know you're in very capable hands of Panayotis, Natalie, and Alkis, who will guide you through this way and help you to master the system as smoothly as possible. Thank you. Evkaristo.
Thank you very much. Thank you. I hope we will arrange an offline meeting in the future next year, and we will be very happy to see Leonid here in Athens. And thank you again so very much. I would like to thank the participants. I hope you received the valuable information from the webinar today, and please, you are welcome to refer to us after, and we will be happy to assist you further. Thank you very much.
Thank you very much. Good luck.
Thank you so much.
Thank you for everything.
Thank you.
Thank you.
Bye.
Bye.